When I was told that I need to see how one can achieve success on medical mission, I wondered, what is this medical mission like? And I think, what is the calling of a good doctor? You must get feeling connected to purpose and values of medical profession. And what is that meaning? To offer holistic health care. That is what is the calling of every doctor today. Now, what is holistic approach? We have to use all the natural endowments that every human being has, which means body, heart, mind, and soul. Every act of your in a life must have a use of body, heart, mind, and soul, and this is very important to a doctor. How does it translate into healthcare? The body is knowledge, the heart is compassion, mind is commitment, and soul is conscience. At the end of the day, you are responsible to your own conscience, whether you did your job well or not. Now, to learn all this, it is not congenital. You need to acquire it through study and also observation. And that's why I thought I will give a title of my talk, How to Study and What to Study. I thought this is important because the science has advanced so much, we are lost in all that information. And even then, we need to be good to our patients and very knowledgeable. Now, medicine, is it a science or an art? And I think medicine is a science of uncertainty. At best, we can call it a scientific study. Art refers to practice of medicine, which is based on science. Now, science of medicine is dynamic and it's ever changing. I passed my MD in 1967. It has been almost 55 years, and I can see what I learned, half of it is obsolete today, and I need to therefore learn, unlearn, and relearn. And this is a lifelong process. If you want to achieve success, you need to keep on learning, and there is no end to that. Well, if you look at clinical skills, they existed even before modern technology developed. And even today, those skills are permanent, but science is dynamic. So the skills of examination, skills of make a diagnosis is just not changed. It's permanent. It cannot be replaced even by modern technology, and therefore it's important even today in the most modern era. If you look at art of medicine, what we refer to as, besides the clinical skills, that is also an age-old ethics. This is known to our country from generations. And the value of ethics have been changing depending on how the medical practice has changed or the community has changed. But it is age-old ethics as a permanent thing. And each of us must be very aware of this kind of a system of moral principles that apply value and judgment to our medical practice. I think we need to learn science, yes, of course, but don't forget it is so dynamic that you will have to keep on learning for life. And one author has said that if you have to run twice as fast, at the end of that you find that you are at the same place. That is what science is developing fast. And another author has put it so well. He has said, check your pulse, you may be academically dead. I think the message is clear. We need to continue learning, continue studying. But two things are permanent. One is skills of examination and diagnosis, and another is ethics. It's ironical that most of us were taught science but not arts. And I'm happy today, some way the MCA has taken a note that we need to have the art or an ethics, philosophy, culture brought in the treat-wide curriculum. But I must say that classrooms do not teach us. We must have a hands-on experience. And I again urge that whatever is permanent, we have to master it. Whatever is dynamic, we have to keep on learning. But today we find that even what is permanent is getting replaced by what is modern technology. Just a word about medical ethics. It's very complex, and we all know that it is do no harm, try to do good, beneficence and non-maleficence, plus the autonomy and justice. But beyond that, there are many mid-level principles like health maximization, efficiency, proportionality. This is an important part for all of us to learn, and I'll show you in the next slide what I mean by that. And I think finally, the most important foundation of medical ethics is doctor-patient relationship. We all must learn. And how will we learn? Only by role models and observation. It's not learned in the classroom. What we learn in the classroom is not what we have really learned. And when I talk about equality and equity, the equality means we treat everyone the same way, but it works only when everyone's needs are similar. Look at this picture. Everyone's needs are different. And if that is so, we must have equity, which means treat everyone as per the need. Well, overall, equity is the means of equality of the outcome. What I want to convey is that you cannot have an excuse to say, I have so much of work. You need to decide to give more time to somebody who needs it, and maybe a lesser time is enough for somebody who doesn't need much. That is the way you can do best for the majority. Coming back to science again, learning science of medicine is first the information. Today we have a plethora of information which is easily available. I must reiterate here that the lectures must not just give information. Lectures must give something beyond information. Students can learn information by varieties of ways. And therefore, today's teachers must know how to give a lecture, not just by information, but the analysis of information. And we all need to choose what we want to collect information for, because information is so vast. You will have to choose first what is basic. Basic knowledge is a must. Even if you are a well-known super specialist, you are not fit unless you have a strong basic general knowledge of medicine. So every specialist should be an excellent generalist. Only then he can do justice to his super specialty. And I think we need to choose information what is most likely to be useful for my practice, for my patient. The rest of it, yes. But if you just listen to information, like what you are listening to my talk now, you will hardly retain. I'm sure at the end of half an hour, after my talk is over, you would have almost forgotten everything. But if you retain a little. But if you interact, you may interact with yourself. Best way, of course, is to interact with your colleagues. Then only you retain more. And then if you keep on practicing, you retain the most. So friends, interact. The learning should be interactive, and then you practice. That's the way you retain information. But we just don't want information. We want a knowledge. Now, what is knowledge? Is different from information. Knowledge is practical application of information. I have a lot of information, but I don't know how to apply, how to put it in practice. This needs a lot of thinking. And I think only when you think, you can digest information, you can absorb, you can utilize, and you can store. Same way that we take food in, but it has to be digested, absorbed, utilized, and stored. This is possible only if you think. I am amazed to tell you that when I have asked over years, even the postgraduate student, why does anybody get fever? Oh, very few can tell me correctly. Most of them say it's infection. I tell them, tell me causes of non-infective fever. Then they come out with inflammatory, non-infective disorders. Then I say, tell me causes of non-inflammatory diseases. Oh, then what is common to infection, to non-infective inflammation, to non-inflammatory disorders? Why every disease of that kind get fever? This is basic knowledge. Otherwise, every fever patient gets an antibiotic because they have not thought what that fever would mean. This is the difference between information and knowledge. And I think unless we think, and how would you think? You'll have to be always trying to find out why is it so, what is it so. You must be inquisitive. Unless you are inquisitive, you cannot know what is right, and unless you think, you can't be inquisitive. We realized over last 10, 12 years that students don't think. They just listen and vomit out whatever they have learned, and they forget thereafter. So we started a program called STEER, which is sensitizing to think, enabling excellence and rationality. We started this program for pediatricians. We have done over 120 programs over the last 8, 10 years, almost all over the country. And we have also done now this kind of program to undergraduates. And I must tell you that when I went to the dean of one of the prime medical college, who was very much keen on medical education, and I told him, I want to give undergraduates an exposure to how to think. He was very happy. He put me to the medical faculty of the hospital, and they came out telling me that, sir, students will not be interested because nothing of this is asked in the examination. Now that is our problem. So are we just now as students learning only to pass exam? For today, every student in medical college has come out with 100% marks. They are bound to pass, but they must learn. Passing is different than having learned. And I think I want to inculcate to students that we need to think, and this is true for whole of our life. At the end of 55 years of practice, I need to learn every day, because I find more I learn, more I know I don't know. And I think, how do I learn? It has to be a deliberate, effortful, mistake-laden, repetitive practice. What does it mean? I have to make special efforts and find out what are my mistakes in understanding a given topic. Once I know what are my mistakes are, then I go on again repeating the exercise, and with repetition, deliberately trying to find out what I don't know, what are my mistakes. It is a great effort, but that's the only way to know well what you don't know. And to know well, you must know first what you don't know. And how will you know what you don't know? Only by deliberate, effortful, mistake-laden, repetitive practice. I feel this is the crux of my talk, that this is the way all of us must lead, and I'll explain to you what it really means over time. But having said knowledge, most of us, including me, have not got wisdom as yet. But what is wisdom now? Wisdom is knowing when and where to apply knowledge. Look at how from mere information we try to gather knowledge, and having got a knowledge, we have to know when and where to apply it. Otherwise, today in modern era, you do all kinds of tests just to rule out every possible thing. That's not knowledge. And just to give you a simple example of what knowledge and what wisdom means, knowledge tells me that tomato is a fruit, but wisdom tells me don't put it in a fruit salad. That means I must know where not to use it. Today, we need to try beyond the knowledge to start getting a feel of wisdom. I know it's impossible, probably I haven't got it. But if I am aware that I need to try it, then one day I might as well get it. But look at what is current scenario of medical education and practice. Students gather information and remember by rote learning. If I ask you, why do you say so? They said, no, this is what I have learned. There is a lack of interactive training. I think gone are the days when you sit in a lecture hall and listen to that. I think generations ago, the father of modern medicine knew that you have to move to the wards, you have to move towards patients, and the patients are the best teachers. Of course, you need a guidance. And unless you do interactive training, and today teacher must hold the interactive training. We have been holding postgraduate sessions totally interactive. There is no monologue. And in our postgraduate sessions, which are going on weekly for years now, we are about 6 to 8 teachers teaching at the same time. Each one has to give some additional value. And imagine, none of us knows everything, but when we have multiple teachers teaching at one time, there are a lot of advantages. One is, if I don't know something, my colleague puts it up, so the knowledge gets wider. And most important is, at the end of that, occasionally, not rarely, even all of us teachers of some experience come out saying that we don't know. when I tell my students I don't know, I have taught them one thing, that it is not a shame that you don't know, but it is also a fact that medicine is so vast that nobody knows enough. I think today's student has a lack of exposure to community common problems because most of the training is based on inpatients from tertiary care hospitals. Today, my postgraduate in pediatrics knows neurodegenerative disease, but he may fumble with something very simple in neurology because he's much more exposed to it. And when he goes in practice, he will degenerate himself because he will not meet a neurodegenerative disease. And he will not be a good doctor for his profession. The examination oriented training is what today's training is. And I think it's not conducive for practice. We must have a good role model for clinical skills. I recall my teachers asking me on rounds, just observe from a distance and give a diagnosis. I used to tell my teacher, sir, give me at least a major complaint. He said nothing. Mere by observation, you start talking, what do you observe? Whether he's sick, whether he's comfortable, whether he's tachypnic, whether he's breathless, whether he's pale, so many things you can observe. And I think the skill of observation has to be learned from such role models. Today's training is emphasis on high tech instead of high touch. Just a few months ago on our PG clinic, which is webcasted, we were discussing something clinically and one of the persons wrote on a chat, sir, why do you waste time? You can do a CT scan, you will know everything. I had to tell them that we are trying to develop skills of clinical judgment. We can't go on asking CT scan for everyone. And you know that today we do not know what is the amount of radiation safe for children, we can almost presume that it's very unsafe. So high tech is important, but high touch is most important. And I recall in 80s, that long, when I went to Detroit, I found in an intensive care unit, nobody was touching a patient. Everybody was looking at the monitor and also the test. When the dean asked me what was my view about what was I seeing, and I told him that how can you not even touch a patient? And I think touching a patient gives some kind of a wave pass between the doctor and the patient, and that helps to build up a rapport. And I think that is most important for developing communication, counseling, documentation. High tech cannot take anything of this kind. And I think with this kind of what training, when we get into practice, what is the result? There is a loss of faith, trust, and respect for doctors. And it has lowered the dignity of profession. Today, if I'm traveling somewhere and a man sitting on the seat next to me asks me what I am, I'm a little concerned to say I am a doctor because he tells me stories how doctors misbehave, stories how doctors are not very empathetic, very good to patient. They don't talk, they only ask for tests. This is what is almost happening today everywhere. Now, if you look at that, we are not the only one. We are not the only one. All over the world, this is happening. And look at this in 2016, just 5 years ago. American Medical Association held a funeral service for physical examination. And what it said, history taking died long back. Now physical examination is also dead. We are almost following the Western medicine. And these are the two books which are worth reading. When doctors don't listen, it has been known that when we take a history, we interrupt the person who is giving us a story because we are in a hurry to make something out of it. We have to listen. Hearing is different from listening. And how doctors listen, this book says how we don't listen. And this book by Jerome Groopman titles How Doctors Think. And in every real case, not virtual, in 10, 15 years ago, those cases happened in Boston. This man is citing those cases to demonstrate how doctors don't think. I think, therefore, the crux of the problem is we need to think. And going back to the basics, the history, I think when patients come to us, they come with symptoms and expects a diagnosis. But the textbook starts from diagnosis and tell us what symptoms such a disease has. So we have to learn a symptom approach. The textbook gives information, but does not give us an approach. Knowing this, me and my colleagues, we are a big group of 6, 8 devoted teachers who spend one evening on a weekday not practicing on that day in teaching voluntarily. And with me, my colleagues, we have written books which are branded now as Lessons from Grand Rounds. We talk about the symptom, we discuss what they mean to us, then we anticipate physical signs, then we give the physical signs, and we ultimately discuss what it means. I think this approach is most important and basic, and as I have already said earlier, this is permanent. This we have to learn. And what does detailed history should arrive at? First thing, it should arrive answers sequentially. First answer I want from a history, anatomical diagnosis. What is the site of disease? Next is pathological diagnosis. What is the type of disease? Third is etiological diagnosis, what is the cause of disease, and lastly, functional diagnosis, if there is a functional impairment, if any. Imagine, unless you know where is the site, you cannot know the type. And unless you know the type and site, you cannot guess etiology. And then you have to decide whether that particular organ is functioning well or not. Did you take a note that we were trained in the same way when we joined medicine? In the first year, we learned anatomy and physiology. And then we thought, we are finished with it. No, where we will need it again. No, we will start the diagnosis with anatomy. Of course, as the time goes, we will use clinical based anatomy. And then we learn pathology. And what is pathology? A disturbed physiology. Unless we know physiology well, how can you know disturbed physiology and therefore pathology? And therefore, our forefathers decided to teach us anatomy, physiology, biochemistry first, and then get on to pathology and pharmacology and start using it side by side on live patients. And this is the format. So every time when I'm teaching postgraduate, at the end of the history, I ask him 4 questions. Tell me the site of the disease, type of the disease, cause of the disease, and whether anything functions. If you are told that this child has got a mitral stenosis, the diagnosis is not complete because I don't know etiology. Then you are told it's a rheumatic mitral stenosis. Even then the diagnosis is not complete because one of such patients may be an athlete because he has got a very minimal stenosis. Another is dying on an ICU with cardiac failure and rhythm disturbance. So for a diagnosis to be complete, we need to have all 4 components. And many times my students tell me the diagnosis is tuberculosis. Oh, they have told me etiology straight off without letting me know where's the and what's the type. Does it make a difference? Of course, yes. The prognosis is different. Duration of treatment is different. And therefore, first anatomy, next pathology, third etiology, and lastly the function. And believe me, history taking is an art. And I call it an art of thought in action. What does it mean by thought in action? Each question has a purpose, and the answer to which leads to the next question. I'm sure all of us start our history taking by asking the name of the patient. What's the idea of knowing the name? Does it matter? Yes, it does. By addressing his name, we start developing a rapport with him. And my next question is, what is your age? How does that matter? Oh, some diseases are known to occur at a particular age and not at any other age. So when I ask a question, what is age? I must know what is the inference of that. And it's not like a robo that you ask questions and you finally say, I have taken a history. And I think, therefore, history is not history. Many times the parents or the patient tells many things which are not relevant. But you need to pick up what is relevant and therefore ask him questions with thought in action. Each question has a purpose, the answer to which must lead to the next question. Once you get a feel of this skill and you know the history, you get 80% of the times a diagnosis. Believe me there. And if you don't, go back to the history and find out where you lack. And then what's your next exercise to learn medicine? Before examining the patient, on one sheet, you put down what abnormal findings you expect. And you will not believe me, in pediatric practice, I teach students how to guess weight, length, and head circumference of an infant only on the history. You can be nearly right. Well, even the weighing balances are different. That is the power of thinking and power of analysis. Practice that. That's the way to learn. And every time when you take a history, you put down your provisional diagnosis and put down what examination findings you expect, and then see whether there is an actual findings are same or different. And this is the way to learn medicine. If you find discrepancy, go back, learn. I've already said mistake laden, effortful, deliberate, repetitive practice. Now, I'll give you some examples what I'm talking. Every symptom could represent multiple systems. And we must think, given patient with a given symptom, which system he belongs to. That is anatomical diagnosis. For example, if he comes with a cough, it could be a primary respiratory disease, but it's important to know that if the cough is significant or a major symptom, it's mostly airways, whereas in lung parenchyma, in pleura, in interstitium, and in lowermost airway, like a bronchiolitis, cough is mild or even not there. Now, this is the way we understand simply by asking a question. Oh, are you coughing badly? It must be an airway. Oh, I am coughing very minimally. It could be a lung parenchyma or a pleura. Oh, I have no cough, but still respiratory problem. It could be even bronchiolitis or interstitial. But cough could be a cardiac problem, where moment this patient of cough comes to me, I ask him, is your breathlessness a major symptom or do you have a palpitation? It will guide me to cardiac disease, or it could be a GERD and an aspiration syndrome. It could be a neurological problem and therefore aspiration and cough. Can you imagine, merely because he has a cough, you can't give him a cough syrup and send him home. You need to find out which system. Same thing about vomiting. Primary GI, either upper or lower, yes, bile stain, not stain, but secondary to the CTZ, the center in the medulla, which gets either stimulated by metabolites or by raised ICP. And that's why with acute renal failure, chronic renal disease, adrenal disease, liver disease, everyone vomits. And even the respiratory disease vomits after a cough, and even ear. Vertigo ends up with vomiting and an autonomic system. When you see a long drawn races and at the end of a big exercise, a person may suddenly vomit, or if you suddenly get into some shock, you may vomit. Will you just give an domperidone and send him home? No, you will give a thought. Same is about breathlessness. Is it respiratory? Is it secondary to neurological, secondary to cardiac, hypertension, anemia? Is it a muscle disease involving heart muscle like a Duchenne muscular dystrophy? Or it is not really breathlessness but only tachypnea and it's an acidosis. Similarly, if you got a high colored urine, it could be jaundice, and a jaundice could be hepatocyte or a biliary tract, but it could be hematological problem, bleeding, it could be hematuria, renal or interstitial, or finally it could be only ingested pigments in the food also. This is the way we first define anatomy, but history has the power of defining microanatomy. And give me an example of few of these. In a respiratory tract, significant cough is airway. If it's dry cough, it's upper airway. But take a note, pharynx is a part of upper airway, but pharynx has no cough receptors. So, if a child of pharyngitis is coughing badly, he has also involvement of larynx or lower airways. What's the idea of knowing this? It straight away becomes a viral infection. But if you have a bacterial pharyngitis or a pharyngotonsillitis, there is no cough because pharynx has no cough receptor. Western people need a throat swab or a antigen to find out. We have enough way to find out whether it's a bacterial or viral by only saying cough or no cough in pharynx. Is it not important then to know the basics, how useful such things are? And if it's a wet cough, cough is more than tachypnea, it's mostly a proximal large airways. And as you go distally into the airways, the cough becomes less and the tachypnea becomes more. Just by asking, how is your cough and how is your breathlessness, you have microanatomy, not only a respiratory tract, and in lung parenchyma, you have a mild cough and breathlessness as a major picture. But can we use anatomy also here? Yes. For example, if it's a pneumonia, then it is localized to one lobe. And here we learned surface anatomy of the lung. If you recall your old days, then we knew that there is a great fissure and a small fissure, lesser fissure. And right upper lobe is only right anterior half. Right middle lobe is right anterior lower half. And the entire lower lobe is only posterior. What does it mean? In pneumonia, you get signs either upper lobe, right upper half, middle lobe, right lower half, and lower lobe only findings posteriorly. Oh, you know microanatomy, which lobe is involved. And the signs are unilateral, whereas in an airway, signs are generally bilateral. Pleural we know by pain. And what is pleural distribution? I told you what is the lobar distribution by surface anatomy. Now pleura is all over, so there is no distinction, and my findings are anteriorly, laterally, and posteriorly below a particular level, depending on how much fluid is there. Is it not easy to differentiate pneumonia from a pleural effusion just by knowing surface anatomy? This is the way we use anatomy, physiology every day, only if we think. And the interstitium has bilateral signs, but hardly any cough. And if you talk about acute respiratory failure, cyanosis is a late sign, but encephalopathy is an important symptom. What has that told us? Brain cells depend on oxygen every minute. Even if 1 or 2 minutes oxygen supply is inadequate, the brain starts showing some discomfort and a stage of confusion, going on to drowsiness, going on to coma. So remember, the first sign of an emergency is a brain showing some abnormality of function. We call it encephalopathy, but encephalopathy doesn't mean coma. Any first impression. And I recall a child of pneumonia who the mother felt was not improving, but my registrar said, "Sir, fever is almost gone." I asked the mother, why does she feel is not improving? See, another point for pediatrician to remember is mother knows more than a pediatrician. If this mother told me she was not happy, I found out when I asked that boy, 8-year-old, he was conscious. I asked him, show your tongue. He did not show. I asked him, where is your mother? He looked around even when mother was standing in front. He was hypoxic. His fever had disappeared maybe, but he required oxygen. And I think how each of this is important. Same thing is about the liver. When I get a liver disease, I tell the postgraduate student, don't call it liver disease. Tell me whether it's a hepatocyte disease or a biliary tract disease or a venous disease or a reticuloendothelial disease. This is microanatomy. And it's easy to know. Acute liver disease has jaundice. He looks sick. He has a tender liver. A chronic liver disease may not have jaundice, but he has an edema. He's chronically sick. He may have a portal hypertension. He has a hepatosplenomegaly and ascites. If it's the biliary tract, he has a very deep jaundice and has clay-colored stools and itching. But initially, he's not very sick, like a hepatocyte disease. And when you have a venous obstruction, portal venous obstruction, if it's pre-sinusoidal, you have only a spleen. If it is sinusoidal, you have liver, spleen plus ascites. And if it's a post-sinusoidal, then you have only liver and ascites. How simple. So we will not call it a liver disease. We will call it a venous system disease, portal venous system disease, inferior vena cava system disease. And if it's an RE cell, then you have a large liver and spleen, but no dysfunction whatsoever, no edema, no ascites, etc. Same thing happens with acute liver cell failure. Besides encephalopathy, of course, you also have a bleeding. Same thing is about the renal. Don't call a renal disease, call it a glomerular disease or a tubular disease or a collecting system disease. What are we looking at? Microanatomy. And can you go beyond microanatomy histopathologically? Yes. In glomerulars, you can find out by history alone whether it's an endothelial disease, epithelial disease, or an interstitial disease. How do you do that? Simple. Endothelial glomerular disease has oliguria, hematuria, mild edema, and hypertension. Whereas if it's an isolated epithelial disease, you have massive edema, but without anything else. And if it's an interstitial disease, then you have hematuria without anything else. Of course, very soon, all of them get over with each other, and you get a combination of this. But it's possible to diagnose even histopathologically only by history. Can you imagine the power of analysis of history? If you can find out that a given child of hematuria has an interstitial nephritis because he has only hematuria and he has nothing else, you can refer him to a nephrologist saying that kindly do electron microscopy and biopsy to confirm that it's an IgA nephropathy, the commonest cause of such immunological interstitial nephritis. You must teach even a super specialist. He would ask you, sir, how did you know only on history? Can you imagine again a power of that? When it comes to tubular, you have hardly any renal symptoms because all are metabolic. And you can even guess whether it's a proximal or a distal tubule because proximal tubules loses everything. Almost everything is absorbed normally by proximal tubule, whereas the distal tubule takes care of largely the calcium phosphorus. And therefore, you might have a calcification. They may present with only rickets, vitamin D resistant rickets, or they may present with only acidosis, tachypnea, and may be mistaken for a respiratory or a cardiac problem and given oxygen and nebulization. Of course, when it's a collecting system, you don't have anything wrong with glomerular tubule, and you may have an upper or a lower urinary tract and so on. But when it comes to the acute renal failure, again, it's an encephalopathy. But look at the fun. Every organ, if it fails over a long period, then it fools you. Chronic renal failure patient presents you to multiple specialists, and he may go to an endocrinologist for short stature. He may go to hematologist for resistant anemia. He may go to cardiologist for a uncontrolled hypertension. He may go to a psychiatrist for an abnormal behavior. And finally, he has got a chronic renal failure. What does it mean? Every super specialist must know basic general knowledge. Otherwise, endocrinologist will do all hormonal tests. A cardiologist would do all cardiac tests. Hematologist will look at bone marrow. Orthopedic surgeons will do x-rays. But if they saw short stature, hypertension, pallor, then they would know that this does not represent their own system problem. This is where every doctor must be strong in basics, and a super specialist has to be a best generalist. If he is not worth his super specialty. Well, neurology is totally like mathematics. Neurology is mathematics. Every symptom that you get, you would know that. And it's important to know that if somebody has a coma, then it could come from a bilateral cortical lesion or a thalamus or even a brainstem reticular activating system. Now, clinical examination can differentiate a brain cell reticular activation with the brain stem, and it's so simple. We we do what is known as a doll's eye sign. If the cortex is gone, but the brain stem is intact, you get a doll's eye sign. Now, simple test can differentiate whether the cause of coma is in the brainstem or higher up in the cortex. Same thing about every symptom. I won't go into the details, but I want to impress on you how symptom-based analysis will give you an anatomy and also microanatomy and sometimes even histopathological diagnosis. Are you convinced what is the power of good history taking? And that's why I said history gives you 80-85% diagnosis. Spend lot of time taking history. Imagine a CBI who is inquiring multiple problems today, spends hours and hours, and we see in the media so and so was questioned for 8 hours. History taking in medicine is also important. If you spend 20-30 minutes with a patient, spend 80% of the time with history, but it has to be a purposeful, deliberate, mistake laden teaching and training. Don't forget that it's an art. We must develop that art. Well, having talked about anatomy, let me tell you whether I can guess pathology also by history alone. What pathological term do you recall that you learned in second MBBS? Inflammation. Acute inflammation has pain, warmth, redness, swelling. We know all that. Chronic inflammation has systemic symptoms with very minimal of pain, warm, redness. I'll give you an example. If you see an acute lymphadenitis, you get pain, warm, red swelling. But if you see a chronic or a subacute lymphadenitis, like tuberculosis, then patient would say when you press, it hurts a little. But it's not very painful. It's not red. It's not warm. It's certainly swollen. But he has a systemic symptom like loss of appetite, loss of weight, etc. That becomes a chronic inflammation. So from today, if you see a lymph node, you don't say here's a lymphadenopathy. You don't call it lymphadenitis unless there is an itis there, unless there is an inflammation there. But other pathological terms we learned about infarction, and we know infarction, the damage is localized to a supply of the blood vessel. This is important to know because it could be an arterial infarct or a venous infarct. And again, arterial infarct could be infarct in the ischemic infarct or a hemorrhagic infarct. Each one of them gives you a different history. If it's an ischemic infarct, you just get a damage and the patient may be fully conscious. If it's a hemorrhagic infarct, the damage is a little widespread. But if it's a venous infarct, you get encephalopathy because once the veins are obstructed, there is a cerebral edema. So if you get a patient of infarction who is drowsy or comatose, you expect it could be a venous infarct. Again, we know by pathology what it is. Same thing about congestion. If you have an acute congestion, you may get pain like an acute congestive cardiac failure. But if it's chronic, then there may not be much pain or a very minimal pain. What about degeneration? Degeneration is, in the history, progressive loss of function without swelling. Look at Alzheimer's. There is no swelling. There is a progressive loss of function. And you have heard about infiltration of tumor, which is a localized swelling without loss of function. And finally, You may have atrophy or hypertrophy. I'll give you an example of all this. Suppose I see a large liver. If it is acutely painful, tender, enlarged, I call it acute hepatitis. If it is very minimally tender, but there are whatever systemic symptoms, I may call it chronic hepatitis. If there is a large liver, but it has been going on for a very long time with deteriorating liver function, I call it a degenerative process. It could be cirrhosis. And if I have a large liver which has a localized swelling without dysfunction, I call it a hepatic tumor. By simply knowing basics and basics of history and examination, I can almost diagnose the pathology to an extent. After all, if it's a tumor, you will know only by tumor histology. If it's an infection, you will know only by further tests, but I will not have to search for multiple tests. I will have a specific test. And that's the beauty of all this. What about pathogenesis? Every pathology has some genesis. And I'll give an example of few common symptoms and how you look at it. Suppose you get a patient with pain anywhere in the body. Pain is caused by inflammation, vascular obstruction, neurogenic, psychogenic, or referred. Every pain fits in one of these five genetic patterns. You know inflammation by symptom, you know vascular by localization, you know neurogenic by character of pain, burning, by radiation, and you know referred pain. Every time, don't forget a referred pain. I see a hip joint disease where a patient comes with pain in the knee joint. And why is this referred? I'm sure you all know how a left shoulder pain may be a myocardial infarct pain. Because the neurological segments are shared by two different sides, and therefore the pain may be referred. So you get an upper abdominal pain, it could as well be a diaphragmatic pleuritis and not an abdominal pain. And you may have to look very carefully whether the pain fits in one of these things. Same thing about breathlessness. If you see a breathless child, he is anoxic or hypoxic. There are four types of anoxia. Is it anoxic anoxia or hypoxic hypoxia? It is respiratory. Is it anemic? It's hematological. Is it stagnant? It's cardiac. Is it histotoxic? Rare. It may be cyanide poisoning or something. Again, a pathogenesis helps. Suppose you see a patient in shock. Is it hypovolemic? Is it septic? Is it cardiogenic? Is it neurogenic? Or is it anaphylactic? A good history can point out to the genesis, and you will make a diagnosis to be very narrow in your differential diagnosis. And if you have got a vascular problem, then suppose you have a sudden hemiparesis and you say, oh, it's a middle meningeal vessel involvement, then every vessel involvement could be thrombosis, embolism, hemorrhage, vasculitis, or a vasculopathy. Whatever I said, having said it's a vessel disease, you can go further and say what kind of vessel disease it is. Well, as I said, it's not 100% right, but you get 80 to 85% diagnosis and you add examination, to me it becomes 90%. Don't forget, this is so important. Lastly, do you guess etiological diagnosis on the history? Yes. How do you guess that? Well, there are many causes of diseases. Infection, non-infective inflammation, allergy, metabolic, vascular, neurogenic, physical, deficiency disease, poison, toxin. How do you know all that by history alone? Use adjective. Is it sudden, acute, or subacute? Is it persistent, recurrent, or episodic? Is it static, progressive, or improving? And I'll give you an example. If it is sudden, it is physical, vascular, neurogenic, allergy, or metabolic. Infection never starts suddenly. If somebody said, I suddenly got breathless, suddenly maybe ultra sudden, like inhaled foreign body or a sudden pneumothorax, or it could be pulmonary embolism. So vascular, sudden seizure could be metabolic, a sudden breathlessness could be immune mediated. So five things happen suddenly or acutely in medicine, of which four may suddenly disappear also. But physical trauma doesn't disappear. And one of them is very often recurrent, allergic. How adjectives can make us guess the etiology. Look at asthma. Asthma is acute onset, recurrent, but episodic nocturnal. What is the difference between recurrent and episodic? You know, episodes come in channels. What is episode? It comes at the same time in the same way. It is continuation of process. So asthma is not only recurrent but episodic, nocturnal. Sir, whole day I'm all right. Only in the middle of the night I get an attack. How important it is to use adjective. I will end up my discussion with a case that is real and how I could teach postgraduate what is the value of history to make a difficult diagnosis. This child came with a symptom of tiredness over last 2 months to accustomed exertion. His mother told us that last few months he is reluctant to go out to play, but last 2 months he just wants to sit. And when you ask him, he says, I have nothing wrong, but I don't want to play. He was getting tired. There were no other symptoms. Clinical examination was normal. I asked the student, where is the anatomy of tiredness? It was not easy. See, cough, vomiting, diarrhea, it's easy. Where is who is getting tired? The muscles are getting tired. So anatomy is generalized muscle. We got an anatomy. What was the pathology? Was it inflammation? No. No symptoms of inflammation. Could it be degeneration? No, it's not for a long time, slowly going downhill. Then could it be a tumor? No, it's not localized, it's generalized. So now it's a myopathy, but no inflammation, no degeneration, no congestion, no infarction, no infiltration of tumor, no atrophy, hypertrophy. Then what is the pathology? Pathology is a functional myopathy. What does it mean? Muscle cannot function, but there is no other pathology. So next question was, what do muscles need to function? They need oxygen, yes. They need glucose, yes. They need intracellular ions like potassium, yes. So let's see, who produces oxygen? Lungs. Who takes oxygen along? Hemoglobin. Who pumps it? Heart. So it could be a subtle lung disease, subtle heart disease, or subtle hematological disease. Or it could be diabetes, because he has a lot of glucose, but the cells are not utilizing. So I must ask for polyuria, polydipsia, polyphagia. And it could be a potassium deficiency. Have I got anything where he has lost potassium, like a renal disorder or intestinal disorder? Or he's not taking potassium, he's sick. Now, unless you thought about what muscles need and what he must not be getting, you start looking carefully, and you found on examination that there was a mild tachypnea missed by the good doctor. SpO2 was 90 on room air. This turned over in interstitial lung disease. Look at the way of a power of thinking. I will end up by take-home message. Know your basics well to become an excellent generalist first. I'm sure all of you who have gone for further super speciality have gone through this, but seem to now feel that you are wedded to only small part of the body. But don't forget that small part of the body is affecting entire body, and a patient may come to you for many different reasons. So let every super specialist be a reasonably good generalist. Take detailed history, wear a thinking cap, and analyze. Make a provisional diagnosis, anticipate examination finding, compare actual finding. In case of discrepancy, find what mistakes you create. Order specific tests, but anticipate abnormalities. If not concordant, find what mistakes you create. This is deliberate, effortful, mistake-laden practice, which is a perfect learning model. It gives you a thrill and joy in learning, and it gives you a fulfillment in practice. Friends, those of us who are practicing possibly see the same types of cases again and again. Super specialist sees same types of only one system cases. But don't forget, each case may have something unique to teach you only if you go through all this exam. Thank you very much for this opportunity.